Good morning. Welcome to the Stinson Lectureship. In January of 1968, as a chief resident, Dr. Edward Stinson operated with Dr. Shumway right here on the Stanford campus and did the nation's first adult human heart transplant. From that point onward, Dr. Edward Stinson continued with heart transplantation, operating with Dr. Shumway, but also eventually becoming the principal investigator for an NIH P01 grant. A P01 is like a giant, it's like 5 R01s in one. And he was the PI for 2 decades on this grant that basically led the subsequent basic science and translational investigation of heart transplantation, and taking it from a nascent operation to an actual gold standard clinical treatment. Much of the immunosuppression, the monitoring of rejection, the further fine-tuning of the operation, this was all done by Dr. Stinson's translational scientific work. He was also a skilled surgeon in so many areas, other areas of cardiovascular surgery. And if you think about it, Dr. Stinson really defined the concept of the surgeon scientist, the translational scientist, even before that was a popular term. So when we were thinking about who to invite as the Stinson professor, we immediately came upon Dr. Joseph Turek in Duke, who serves as the professor in chief of congenital heart surgery at Duke University. Dr. Turek is very well educated. He only holds 3 graduate degrees beyond his undergraduate degree, so an MD, a PhD, and an MBA. And he's a likewise talented congenital heart surgeon with expertise across so many areas and subspecialties within pediatric heart surgery. But in particular, he's a pioneer in transplantation, just like Dr. Stinson and Dr. Shumway. He is known for numerous innovative world's firsts, including multiple versions of partial heart transplantation and valvular reconstruction. He leads a highly productive basic science and translational research laboratory, which is funded by an NIH R01 on which he serves as the principal investigator, as well as AATS and other industry grants. He's had hundreds of peer-reviewed publications, and he's trained countless students, residents, fellows, and junior faculty. He's received multiple teaching awards. And very importantly, he received the Duke University Presidential Award in 2022. Dr. Turek also holds multiple leadership roles in both the AATS and the STS. And we're just so privileged to welcome him to Stanford to teach us.
For me, this is an incredible honor. I never thought I would be here, giving a talk at the home of heart transplantation, and then being naive enough to talk about heart transplant at that place. So, but we stand on the shoulders of giants, and that's what Dr. Stinson was to me. When I researched what he had done, it's my disclosure. When I researched what he had done, I realized that he single-handedly pushed this field forward. He pushed it forward from the time of all the seminal work that was done in the laboratory on the transplants on the large animal models, was involved in the operation itself. It was the first in the U.S. And then looking at things like biopsy for rejection and immunosuppression and donor selection. And I mean, these are all the things that we talk about today, and he helped to push forward. So this is again, this is probably one of the biggest honors that I've ever had, is to be able to come and talk at his lecture. So I want to look at some of these same things and explore some of these things in my conversation today. And in pediatric heart transplant, what are some of the things that we need? Number one, we need to figure out how to minimize rejection. Number two, I've said we're going to look at non-traditional forms of a failing heart. How do we expand the donor pool the human donor pool, and then how can we expand the donor pool beyond humans? So clearly, heart transplantation is a gold standard for end-stage heart failure, and we deal with issues with immunosuppression in these patients, whether it's malignancy, renal insufficiency, or recurrent infections. The issue is we suppress immunity, we don't reprogram it. And maybe that's what we should be doing, is reprogramming our immunity instead. So I think that brings us to the thymus. Thymus function is essential. It's a site where T cell selection and maturation occurs. Central immune tolerance is dependent upon the thymus itself. And these T cells are educated within the thymus stroma, whether it's negative selection, deleting donor reactive clones, or it's positive selection, where you're going to ensure that these T cells can actually interact with the self-MHCs. The emergence of thymus transplantation actually is a Duke story. And again, this is understanding your history here. This picture on the right of Louise Markert. Louise Markert was a pediatric immunologist at Duke. She's a professor emeritus now. She knew that children who had bone marrow transplantation could treat SCIDs. However, the real problem was these kids with congenital athymia, and how could we treat those? And she asked the question, could transplantation of the thymus itself correct immune deficiency for those kids? She came across this idea of culturing the thymus. And the idea was that when you have a thymus, if you're going to do fresh tissue thymus implantation, they're loaded with T cells. In fact, when she cultures the thymus, she takes a thymus, she puts it in this culture dish, and you just see it turn milky white in the dish. And that's all the T cells that are leaching out. And clearly, if you had those T cells transplanted, you would be at risk for some graft versus host disease. The other thing is, in culture, there's an upregulation of these chemokines that are responsible for the T cell progenitor homing in the thymus. And then the other piece is that she was able to make them so they could be thinly sliced. And the idea with that is that you can take these really small, thin sliced and be able to get neovascularization in those and diffusion of the T cells into the implanted site. The question is where do you implant them? And this is an interesting story, but Louise was married to Peter Smith for a time. And Peter Smith, the chair of cardiac surgery at Duke for about 27 years. And she was asking him this question: how do you transplant something that doesn't have a blood supply, like my cultured thymic tissue? And he thought back to the idea of what we did with parathyroids in surgery. And that's kind of where the thymus transplantation technique came from. And it's done in the quadriceps, where you have a lot of muscle and vascularization. And she published this paper in the New England Journal of Medicine, which was a real success. You know, these children with congenital athymia largely passed by the age of 2 from overwhelming infection, and she was able to rescue their T cells. And this was the paper on that. And you can see this T cell reconstitution occurs over a course of about 6 to 9 months in these patients. So we started thinking, could we, and Louise and I worked together on this idea, but could thymus from an organ donor reprogram the recipient T cells to be able to accept any kind of donor organ as self? And so we started our studies in a rat model. And in the rat model, we basically took a rat, thymectomized that rat, treated it with anti-thymocyte globulin to deplete peripheral T cell stores. And then we took a heart out of another rat and the thymus and did a heterotopic heart transplant, cultured the thymus for 2 weeks, and then introduced the thymus. And then eventually we weaned off immunosuppression and had no issue with that thymus in the rat. We then took a third-party thymus and put it in the neck as a second heterotopic site, and that heart rejected immediately in those cases. And so we published that data and showed that in fact you could combine cultured thymic tissue implantation and heart transplantation and get a sort of tolerance. We've progressed these studies with some of our NIH funding in both rhesus macaque studies as well as in swine studies. And then this happened, kind of in the middle of doing all this research, and this is the translational part of all this. I had his 5-month-old boy. He had single ventricle heart disease. He had a very poorly functioning AV valve. And I kept trying to fix the AV valve, and I wasn't successful in doing so. And then we decided to list him for heart transplant, but he had all these recurrent infections while he was listed for heart transplant. So we got an immunology consult, and sure enough, he had very, very low T cells, idiopathic low T cells, not congenital athymia, but idiopathic low T cells. So we got an emergency IND approval from the FDA, and the idea was to move forward and perform the world's first thymus heart transplant on this child. Everything went well in the case, in the transplant. What we do is we procure the heart and the thymus from the same donor. We bring it back. We send off the thymus for culturing, which is done at Duke. And then we implant the heart at that time. And then 12 days after his heart transplant, we took him back to the operating room. He was very debilitated to the point where we had to do bilateral quadricep implants. And what you do with these small little cultured thymus tissues, it's about 40 little pieces on tissue paper, and you put them down. And Louise Markert's a gardener, and she calls it planting tulips, because you just push it down in the muscle. And it worked well for this child. He was discharged about a month after his operation. And just like we saw in the congenital athymia patients that Duke treats, this child's T cells reconstituted at about the 6-month mark. And then long-term, he has normal T cell counts. He's had some viruses. He's tolerated them just fine. And he looks fantastic. So we were pretty excited. And then we got a child that actually had congenital athymia, had single ventricle heart disease with a poor, he was hypoplast with poor RV function. And we thought this was the perfect child to be able to do it again with. And we did this heart transplant. Unfortunately, this child died of infections, septic shock, and he had non-TB mycobacterium, and passed away 3 months after his heart transplant with a very well-functioning heart, but his T cells had not reconstituted yet. And I think what we realized is that there's this vulnerable interstage at 6 to 9 months in order to get the thymus to reconstitute, which is going to be our hurdle in the future for doing these kind of things. So I think these are the lessons that we learned. And this is the first child who took his 5-year-old trip to Disney. These are the lessons we learned. Number one, a co-transplanted cultured thymus can reconstitute the T cell repertoire in the face of immunosuppression that's used for full heart transplant. The thymus heart combo allows us for low dose immunosuppression. I think that it could potentially allow us for no immunosuppression down the road, especially in a child who has congenital athymia. And then the athymic patients are at really high risk in this interstage, and we need to figure out how to combat that, and how we can accelerate the T cell reconstitution. And that's one of these NIH grants that we have is on doing that. We need to figure out how to effectively deplete the T cells also. This first child, we weren't able to do a complete thymectomy on him. It was the 3rd time in his chest when we were doing the heart transplant, and I don't think we got all of his native thymus out, which is important. So we need better ways of depleting T cells, maybe using some of these medications like nelarabine and things more powerful than ATG in these cases. The most exciting piece about this is we're working with Sumitomo Pharmaceuticals, who has the biological licensing for cultured thymic tissue implantation. And the idea is we're going to start a trial where we take patients with congenital athymia with single ventricle heart disease, and we're going to offer them initially heart transplant with cultured thymic tissue implantation. So I want to move on to this other idea of addressing other forms of the failing heart. And this is addressing the dilemma of the small child that has a poorly functioning valve. Most of these valves are too small or too large for these small children. The valves don't grow with the children, and homografts don't necessarily last long. And the most extreme case of this is truncus arteriosus. In the world of truncus arteriosus, where you have one artery coming out of the top of the heart with one valve there, what if that valve doesn't work well and you have to replace it? And this is a meta-analysis that we performed. And the results are pretty sobering. Half of the children don't leave the hospital when you do this double root replacement with cryopreserved homographs. Late mortality is 15+% per year, and reinterventions are obviously very high. And the lesson learned here was from Dr. Yacoub. So Dr. Yacoub, back in the 80s and 90s, had this idea about homovitals. And what he was doing is he was procuring fresh valves, conduits, and he was using them for aortic valve replacements. He was doing it for patients that had endocarditis. He was doing it for just standard, aortic stenosis and aortic insufficiency. And what's interesting about it is that when you look at it, he didn't add immunosuppression to these patients, but they were fresh homografts. And if you look at in this series, the conduits, he had a 10-year freedom of reintervention of 94.4%, I believe, in the aortic position for these homovital grafts, which is pretty impressive. I asked him at a meeting, I said, why'd you stop doing it? The results are so good. And he said it was a pain in the ass to get the fresh conduits, So this brings us to what is partial heart transplantation, and there a lot of people have not liked the terminology. I like it because I do think it's a bigger field. I think it's a field of take a part of the heart, whether it's the semilunar roots, the vasculature, the AV valves, basically procure it in a fresh manner, and then preserve it effectively, implant it into your recipient, and add some degree of immunosuppression to keep it alive and potentially growing. It's kind of a marriage of sorts between heart transplant and some of our root techniques. This is just a quick graph looking at some of the differences and what we know similarities between heart transplant, living homografts, which is this partial heart transplant idea, as well as the cryopreserved homografts. And I think in many ways, the living homografts kind of fall in between these two modalities. Should we be surprised that if we do this, if we take freshly procured tissue, implant it, add immunosuppression, should we be surprised that it grows? Well, if you don't have immunologic issues, you take your own valves, you take your pulmonary conduit in a Ross operation, put it in the aortic position, we know that those grow, the annulus grows, the leaflets grow. When there's no rejection, they'll grow. There's also adaptive growth of the semilunar valves. If you look at any heart transplants, obviously when we do an infant heart transplant, they last over 21 years. Those valves have to grow with the patient. So, and when you have heart transplant rejection, you very infrequently have valve failure, which is another important point. So we started doing some early piglet studies. Pigs are a great model for partial heart transplant because they grow so fast. A little piglet in 2 weeks will double its size, and you'll know whether or not the valve that you implanted in that piglet's growing or not. So what our studies would do is we would take a pulmonary conduit from a freshly donated pig. We'd put the recipient pig on bypass, and we'd basically do an RV to PA conduit in the recipient pig, and then we would immunosuppress them, survive them, and see if the valves are growing. Around the same time, I saw this patient prenatally, and that's kind of when I realized maybe truncus is the right place to start for this patient. This patient had severe truncal regurgitation, and I just kind of put that in the back of my mind and waited until the child was born. But I did think that I needed to start getting the logistics going because this hadn't been done before, and logistics are everything in this business. So I, made sure we got an IRB going so we could track this. I talked to the center. Clearly, if you're going to go get a heart for a child, you're not using the full heart. It's probably not going to be paid for your jet travel to do that. So I had to make sure I got approval from Duke for that. Sorry. I actually put together letters to the OPOs that basically said, this is what we're going to do. And I was ready to send those out as soon as we got approval from the family to do that. I talked to UNOS, I talked to the FDA. Neither one of them said that was in their jurisdiction. And at that point, I was like, okay, well, it's kind of the Wild West. We'll just do it. We don't have anyone overseeing this. And then we did some OR pre-gaming, took some CT scans of some truncus, printed them out in some soft plastic, ordered up a whole bunch of pig hearts and piglet hearts, and practiced doing the procurement of the roots. And, I tried one strategy was perform the roots together, and tried that. And boy, that was painful. A little tongue of muscle there to close the VSD. That was a bad idea. And then did it the right way, which was doing separate roots and putting the separate roots in place. Sure enough, this child was born. He was small, 2.5 kilo. Here's the echo, not good, severe truncal insufficiency. And we moved forward and talked to the family. The family asked if I had ever done one of these before. I said 5 piglets, and they said, "Well, I guess this will be your first human." So we moved forward and sent out those letters to the organ procurement organizations. It took 17 days to finally get a recipient. I sent them out nationally too, and we got a recipient, and we treated it like a heart transplant, brought it back right away, and started going. So we got this video. This is the actual first partial heart transplant operation. The procurement of the heart, we would start off with the pulmonary conduit, just like you would for a Ross procurement, and then moved on to the aortic root procurement. This is us ligating the coronary arteries in this patient. One of the things in the pre-gaming that I learned is that, for taking these, the best way was to kind of go through the left atrium and, I could spare not get into the aortic valve that way. It's always a lot lower than you think when you're trying to attack it from the ventricle itself. There you go. There's your 2 aortic and your pulmonary roots that we're going to use for this operation. Here's our recipient, heads at the top of the screen, feet at the bottom. This is us opening up his truncal artery. And we're going to open it up above and below where the takeoff of the branch pulmonary arteries come in. There you are. You can see the right and the left PA. This valve, we're going to take out the valve here, and when you look at the valve, it was thickened, which isn't, it's not terrible, but one of the leaflets was actually missing, so there was really no way that we were going to be able to repair it. This is us taking the coronaries out, coronary buttons. You really have to, when you put these double roots in, you really have to splay open the right ventricular outflow tract. So that's what we're doing here to make sure we have enough space for all of this we're going to put in. And then we start off by, parachuting down the aortic root to get things going. One of the other things we learned in the pre-gaming process was, if you have kind of your mitral curtain on your aorta, you can use that to close your VSD. So this first stitch that I'm taking here is actually going through the crest of the ventricular septum, and it's actually, obliterating that VSD by sewing it to the mitral curtain aspect of this aortic conduit. So once we've sewn the proximal part in, we size the aorta for length, and then do our coronary implantations. Move this along here. This is our post-operative iPhone video of this child. We've implanted aortic and pulmonary. He had good function. We closed the chest on post-operative day 2 in this case. Post-operative echoes look great. Both valves, no regurgitation, no stenosis at all. We waited about 6 months before we announced it because I wanted to make sure the valves were growing and the kid was doing fine. But the valves grew well. They had it on the Today Show. Crazy thing is that 2 weeks after the Today Show episode, I got an email from Grey's Anatomy saying they've already written an episode 2 weeks later. And first of all, I didn't even know Grey's Anatomy. And then they wanted to meet about it to make sure it was accurate. So we set up a Zoom call, and I showed them that edited video. It was already edited like that. And so they asked if they could have that. So Duke gave them the video, and that's part of the show. Actually, is most of it's fake, but there is a little bit of the real video in there. They gave me the script too, and anything I said, I marked up the script a lot, and I said that's not realistic, and this and that. And my daughter read it, and she said, "Dad, you can't say that to these people." I said, "I'll say whatever I want." Well, then we met, and I went through a bunch of these points, and like one of them was the patient was on ECMO. like we all know, you're not going to do well on ECMO with a severely regurgitant truncal valve. I said, that's not realistic, guys. You can't be on ECMO. And they said, we really want ECMO. Can we have ECMO? You can have ECMO. So they didn't give me anything really. I kept bringing up different things. They had the kid in the NICU rather than the cardiac ICU and things like that. So they wanted it all. And I finally said, you listed the heart as being like a walnut. Can you just call it a strawberry? It's the same color and more of the same shape. And they gave me that. So that's the only thing. And the only thing I added to the show. So if it's unrealistic, it's not my fault. So I think the thing I've been most proud of with the partial hearts is the organ stewardship of it. Like I mentioned earlier, there's all these different parts of the heart that you can use. Again, back to Dr. Yakub, one of the really cool pieces of organ stewardship is the domino idea. And this is, so Magdi, in that experience that I was talking about before, he used a lot of patients who were getting heart transplants. Their old hearts were bad because of myocardial issues. The valves were fine. He was using the valves, and those were his fresh valves. He was doing them as dominoes. And so we started doing these as dominoes too. And in our series, I'd say the majority or half or so are dominoes. And a lot of the kids are dominoes because we pretty much use most kids' hearts that are available for full heart transplant. There's another thing that we've kind of termed split root transplantation as part of organ stewardship. And the idea there is you get a heart, and then you take one of the valves and you provide it for one child, and then you take the other valve and you provide it for another child. So aortic here, pulmonary here kind of thing, called split root. This is an interesting story. The third and the fourth partial heart transplants ever done, MUSC, who we'd done some of the research with, they got a heart for a truncus patient, and they repaired the truncal valve and just put it in the RV to PA position. And then they called us up and said, hey, we just finished. We didn't use the other valve, and we know you have a patient who's waiting. So if you've ever driven down I-95 and you're going down between North and South Carolina, there's this really creepy place called Pedro's south of the border. And it's right just south of the North Carolina border. It's the halfway point between Duke and MUSC. And you go there, and it's like an old Wally World, like Disney resort type thing, but it's really shady. Like, I don't think this was the only organ that's ever been exchanged at that place, is what I'm saying. So this is where we are with the Duke. Every time I show this, we're always behind a little bit. We've done 36 now. Truncus is a main diagnosis for many of these early experience, but later on we started using it for TET pulmonary atresia. So our technique was we ductally stent those patients, list them for a conduit, and then when we get a fresh conduit, we do their TET repair and with that fresh RV to PA conduit. An interesting patient is the patient in number 8. Critical aortic stenosis is a newborn, critical AS. That child got ballooned, wasn't effective. Heart function was really poor. And so what we did is we got an aortic root, partial heart aortic root, and we put that in rather than doing a Ross, which shortened the operation, allowed a poor ventricle to get a shorter operation. And the interesting thing about that is you don't take the Ross off the table. If for some reason that didn't work, you can still do a Ross down the road for that child when the heart's better. This is what I know, to my knowledge, who's done partial hearts at this point. I worked with this group in Geneva, Switzerland, and they were the first one in Europe. And then the group in Madrid, I've worked with them as well, and they've have 2 now, I believe, that they've done. We published the initial case a couple of years ago, and then we just published this last year, which was our first 19 patients or so, and it came out with a concomitant article in the New York Times about the early success showing growth. This is some of the images for those patients. Basically, there's a Z-score -1 to 1 that's shaded in there, and then this is actually the trajectory of the valve, of the annular growth in these patients. We heard back from people that, well, is this annular growth or is this annular dilatation? So our pediatric cardiologist came up with a leaflet measuring technique for both the aortic and the pulmonary leaflets so that we can start to track those as well. And this is the pulmonary position for some of those patients. And same thing, a way to track pulmonary leaflet growth. This has been, for some kids that just have not had great options, I think this has been fantastic. I highlight 2 of these messages that I got because, they're coming from, distances, right? And they don't have to leave. It's not like heart transplant where you have to be within 3 hours or whatever the folks' rules are being there. The actual storage of these lasts much longer. Tracking rejection, it's hard. You can't biopsy. At least somebody has suggested biopsy before, but I don't think we should biopsy. But you can use cell-free DNA. You can use donor-specific antibodies. I guess I don't know what any of it means anyway, because again, when a heart transplant rejects, the valves are fine. We looked at immune sensitization in the first 26 patients. A third didn't have any DSAs, a third didn't have significant levels, and a third did have significant levels, but none of it correlated to valve function. The thing it correlated to was previous major surgical intervention, which makes sense. They probably got a lot of blood from prior operations. It plays out the same way with some of the multi-institutional data that we're working on right now for this. We published this article in JTCVS looking at cold ischemic time. We did some ex vivo data that in both pigs as well as explanted cardiectomy hearts, and showed that we thought maybe 7 days was going to be sufficient for cold storage and still have viability, cell viability. So then we did the experiments, procured a fresh piglet valves, put them in cold storage solution for a week, implanted them in the recipient piglet, immunosuppressed, and tracked them. And you can see here on the right side, the native aortic annulus in red and the pulmonary annulus in blue. And then we also do leaflet length measures at the bottom there too. We survived these pigs out a long time. We went full dose immunosuppression for a month. We dropped them down to half tacro only for another 3 months, and then we stopped immunosuppression. And you can see the comparison in growth of sizes between the native aortic annulus and the transplanted pulmonary annulus. So I don't think you need long-term immunosuppression. This is another animal's, or this is the leaflet length measurements of that same animal. This is another animal with the annulus, and then that same animal with the leaflet length measurements. So I do not think this is necessarily a lifelong immunosuppression. Some of the data that I won't show here that we have in the laboratory is that these conduits are cellularized by recipient cells. And it looks like it's happening within the first 3 months or so, depending on the size of the conduit itself, which means that you're not really exposing to antigenic. So another thing we started looking into was expanding to the AV valves. And we worked on this in the piglet model, did a number of these operations. This is what it really is from this cartoon animation. It's more difficult. You're not just sewing 2 tubes together like you are with the semilunar valves. Instead, you're harvesting these mitrals with the papillary muscles intact, and then you're putting them in place. You're securing papillary to papillary with multiple pleated sutures, realizing that if one of those sets free, you've got severe, wide open MR, and then you do an annular suture line around that. And so we found a child, and I'll talk to you more about her in a bit, who was the first mitral valve partial heart transplant. This is another thing that we've done, and when you looked at our list of cases that we had done, we've done about 6 of these now, but we call it a living Ross procedure. The idea is that you're putting an RV to PA conduit in any way that's cryopreserved. Why not put a living one in? Why not use Yaku principles? When we talk to our patients about it, we give them the spectrum of options and let them choose. So the options are tried and true cryopreserved homograft as your RV to PA conduit. On the other end of the spectrum is get a freshly procured pulmonary conduit and take some immunosuppression for that. Stop it whenever you want, but we think you're going to benefit if you take it for 3 months. And then in between is do a homovital like Yaku. Just get a freshly procured one. Don't immunosuppress it at all, because some families don't want to immunosuppress, and they think, for the pulmonary position, is it really necessary? But even for adults, we offer that the same thing. And the truth is, if Yaku's work translates to the pulmonary position, it should be beneficial for the patient. So bringing it all together, this was an interesting story that they did also on the Today Show. But the girl in the middle was waiting for a heart transplant. She was 8 years old, I believe, waiting for a heart transplant. She got a heart offer. We talked to her and her family and said, listen, would you mind donating your old heart for valves? And she said, absolutely. And that's the other interesting thing about the domino. It's 100% donation rate. Everyone wants to donate their old heart because they're getting this gift of a heart. So she donates it. The girl on the right was a freshman in high school, cross-country runner who ended up getting endocarditis. Her valve was really destroyed. And she gets the first living mitral valve from that girl's heart. The girl on the left, who was the star of the Today Show because she was riding around postoperatively on her dirt bike without a helmet, she got a living Ross for her aortic valve disease. So we kind of did a split route in a sense. One got one valve, one got the other. Sorry, and we did a domino as well. So it's kind of all the pieces of organ stewardship wrapped up in one case. We think that there's a lot of applications in the adult. We think that in endocarditis, the home of vital idea should be alive. And if you've sterilized it, maybe it's more than home of vital. Maybe you do add some immunosuppression. I think TAVR explants. We think mitral valve. I think the mitral valve is an adult operation. I don't think it's a pediatric operation. The PAPs become ischemic, and then I think you get a little bit of prolapse from those. I think these are cases where you should do neocords with the fresh valve. You're not going to get growth, but you're going to get longevity, hopefully. The small aortic root needing an AVR, and then obviously the living Ross is another option. I'm going to go into this. This is a kind of a really quick thing. I just want to talk a little bit about expanding the human donor pool and what we've done with this in the pediatric world. Obviously, there's standard brain death and there's DCD. Central to this story is Children's Colorado, who back in the late 90s, early 2000s, did 3 patients that were donation after circulatory death. They were all in-house, less than 30 minutes from the time that they withdrew on the patient until they were transplanting them, the valve, or until they passed, I'm sorry. And they didn't have a means to reanimate. They just basically cardioplegia, took it to the other room and implanted the case. They discontinued this due to ethical concerns, and we're getting a lot of that right now. What we're doing in the pediatric world is we're just trying to take from what the adults have done, like we always have, because they don't make devices for kids like this. So we did the first US pediatric DCD with OCS. It was a child who was 14 years old, but she was adult size, so we were able to use that. I don't know if you ever heard this story or not about Jacob Schroeder. It's a far right picture. Somehow the patient came in late for the heart transplant, and they already had the heart back, and Jacob went to talk to the patient preoperatively and realized the guy's heart was in the room next door, and he asked the guy if he wanted to see it. So that's Jacob showing the guy the heart on the OCS device. NRP is another way we can do it. This is great for kids in the sense that you're reanimating the heart in the chest. You're clamping the head vessels so you don't reperfuse the brain, but you're reanimating the heart in the chest. And for pediatric, we realized that if we don't have a device, this is probably our best option. So we really embrace this. We did the first first US pediatric DCD with NRP, and then we really started to expand our program. We have the largest program in the world now for pediatric NRP. A whole lot of process to it. I mean, it just takes a lot of team. This is just a picture with all the different gear and things that we have to have, and the team. We take 2 surgeons, we take 2 perfusionists to go and do it. One of my junior faculty gives this talk a lot, and he says, what's weird about this picture in the middle? Number 1, the heart transplant procurement's happening during the daytime, and number 2, Joe Turek's going on it. So I do go on these actually, but this is just, there's a whole lot of steps to this process. We've done this. This was a publication we had when we had done 10 of them. We had a successful procurement, 10 successful. We had done 13 procurements. 1 heart didn't reanimate, 2 didn't pass away in the time limit. This is the most important take home of the NRP. Our waitlist duration plummeted with the institution of DCD NRP. We're getting hearts and getting kids transplanted within a month. And the perioperative outcomes were similar. We also looked at this device in order to transport for longer distances, because when you do NRP, now your heart's in cold storage. So you can't go too far away to get your NRP unless you use a device like this. So we use this ex vivo device for for doing that. And this was the first one in the US. I think this might be a really nice device. It doesn't reanimate for you, but it might be a nice device for longer term preservation. And then we started dealing with issues where about half the hospitals didn't allow us to do NRP because of concerns of reperfusion of the brain. So we came up with this new technique where basically we took the heart out when the patient passed, we cut the heart out, we go to the back table, and it was like our Langendorf prep for the most part. We call it on-table reanimation or OTR, and we revive these hearts just briefly, just to say the heart looks good. And so that's in a situation where these hearts, maybe it took them an hour and a half to pass, and you're just not sure that you're going to want that heart unless you can see it. It's not loaded, so it's not perfect, but you're at least able to see it. And we've done 4 of these now. 3 of them, we were happy with the hearts and we brought them back. There's kind of our setup. We have a device now that we're putting together for it. And then the final piece I just want to touch on just for a few minutes is, I think we do need to still continue to expand this donor pool beyond humans. Xeno hearts, I'm a firm believer they should start with kids, and there's a number of reasons why. VADs don't work well in kids. VADs are destination in adults. VADs are not destination in kids, especially smaller children. So they do poorly on that. There's a paucity of donors for our infant patients. They actually have a favorable immune system. They have this immature immune system that's probably more favorable to be able to receive Xeno hearts. So we have a collaboration now with United Therapeutics, and we're working on this in the laboratory. We're doing, our philosophy is to bridge to allo. The philosophy is not that this is destination. I think we are so far away from Xeno hearts being destination. But if we can bridge, and we can almost like a Xeno VAD for these babies who don't do well with support, then that might be the best thing. So we're doing both full hearts as well as partial heart Xeno in the laboratory. That's just a quick video of one of those. And we're just struggling right now with immunosuppression. We're trying to figure out what's the least amount of immunosuppression we can use in these cases. Unfortunately, it looks like we're going to have to be on pretty significant complement inhibitors, co-stim blockade, and all the things that we normally do for these, because the infiltrates are in these valves, and you can tell the valve on the left is the native valve. Valve on the right is a xenotransplanted valve, and after 3 months, I mean, they're not as immune privileged as you think they are. So anyway, thank you so much for this opportunity. I appreciate it.